Now we're going to spend some time talking about the management of upper tract urothelial carcinoma and what's new therapies and trials that have come up recently. So I have no disclosures related to this talk. And just a quick outline, I'm going to make a quick review, and I mean it's going to be very quick, going over to the pathogenesis and all the epidemiology, treatment and the management of this disease, because there's been some new trials coming up that would impact the way we understand this disease, and then discuss how renal function is an important key consideration in the decision making, and also the new data on genomic characteristics has been reported recently in the upper tract. We're going to talk about the preliminary results from the intracavitary therapy in this disease, and also perioperative chemotherapy. And at the end, if I have a few 1 or 2 more minutes, I'll show an algorithm that hopefully will consolidate all that. So, as you know, urothelial carcinomas correspond to 90% of all urothelial cancers, and they're essentially multifocal. This is because of multiple reasons. We all know they have genetic factors, they have environmental carcinogenic exposure to the urothelial cells, and until not so long ago, some of us would believe that it would be similar to bladder cancer, just like a bladder cancer. Is that really true? We're starting to get more and more input into that. And just like the urothelial cancers in the bladder, they have a propensity to recur very often, and that create challenging scenarios like multiple tumors, different areas affected synchronously or metachronously, and we talked about this earlier. There's always a question if this is a recurrent tumor, the same tumor is coming back again, or this is a new de novo second primary that is popping up in a different area of the urothelium, and there are theories supporting both ideas. So the monoclonality is one of the theories, and also the field effect in the urothelium would be the other theory, and there's preliminary data supporting both. So 5% of all urothelial and 5 to 7% of all renal tumors are urothelial carcinomas. They are more prevalent in men than women at age of 60 to 6th and 7th decades of life. They have a predilection for the renal pelvis over the ureters, and the synchronous bilateral tumors are not so common, but in the setting of a presence of a bladder cancer, then it might happen in 80% of the cases. The risk of upper tract after bladder cancer is about 5% in 5 years. So you all are very familiar with the risk factors. The bulbar nephropathy used to be known just a degenerative interstitial nephropathy. Then later on, it's a very interesting epidemiological story when the investigators were able to associate this with exposure to the Aristolochia fungi. That's a herb that produces an acid, it's the aristolochic acid, and that is very carcinogenic, and it causes upper tract tumors, interestingly not bladder tumors, and a lot of different areas in the world where this disease seems to be even endemic, has been associated with exposure to this acid. So very, very interesting epidemiologic story. Smoking history, as you know, very important, is a modifiable risk factor, increase the risk in about 3-fold or more. It is dose related, and interestingly also increases the risk of tumors in the ureter versus in the renal pelvis. There's other things that are classically discussed, like a coffee consumption, analgesic abuse, chronic inflammation, infection, occupational hazards, and also it's becoming more and more popular now, the hereditary component when you talk about Lynch syndrome. So that's hereditary non-polypoid colon cancer. Is associated with several different other tumors. It's an autosomal dominant disease that involves DNA mismatch repair genes. So renal upper tract tumors are part of this spectrum. So what's new? So this is all we knew so far. So recently now we're getting TCGA data and genomic data coming up. So we have this paper published last year showing the first ever comprehensive genomic characterization of the upper tract urothelial carcinomas, and we're able to observe that FGFR, ApoBec gene pathways, PIK3 kinase pathways, P53, they become very, very commonly mutated both in low-grade and high-grade disease, mostly high-grade disease. If you look here on the right side of the screen, this is an analysis comparing low-grade tumors versus high-grade tumors, and you can see a lot of more gene mutations and activity in the high-grade side of the plot. Down here, it's a copy number variation. Same thing. On the right side, you see the high-grade tumors having a lot more genomic instability and activity compared to the low-grade. And here on this side, same thing at the protein level. So we're starting to understand this a little more, and when we put this together on this hierarchical cluster analysis, we actually are able to divide these tumors in clusters. And there's 4 subtypes. They're molecularly identified, and they can be stratified by the path grade, their behavior in terms of recurrence, association with smoking history. So this genomic division and clustering has to do with their behavior. So we're just scratching the surface here, but this is new data coming up. This is recent data coming from Memorial Sloan Kettering. It was published earlier this year, and what they've done, they tried to correlate the genomic alterations identified on tumor biopsies with the final tumors when they have a matched pair to compare, or versus a database of over 140 previous cases that have been, fully sequenced and that they had in their database. And interestingly, they have a very good correlation. They observe the same mutations, and right here on the right side, you can see the plots of the genetic mutations from the biopsy on top versus the matched pair nephro-U specimen at the bottom. And right here on the right, we have Venn diagrams showing how these findings intersect. So their conclusion is that biopsy is feasible and provides enough material to have reliable genomic material for tests and genomic tests, predictors and other markers that can drive therapy. In terms of diagnosis and staging, I'm just going to fly through this. Hematuria is the most common symptom in the upper tract. Flank pain may be very common as well because of obstruction, not only from the tumor but also from blood clots. You can have low urinary tract symptoms and even consumptive symptoms in patients with more advanced disease. Common sites of metastasis are lungs, liver, bones, and also regional lymph nodes. So many times patients present with symptoms related to metastatic sites. Initial evaluations by imaging, CT urogram and MRI urogram are typically the first test to be done. Intravenous pyelogram is becoming rare and rare, but at the first round we were able to rule out a lot of these possible differentials. But the message is we need to combine radiological assessment with endoscopic assessment. And then because we have the biopsy component as well. So when you have this combination of a radiographic plus endoscopic assessment, the diagnostic accuracy goes up to 85 and 90%. Still, histologic correlation may not be perfect in terms of stage and grade because of the limitations that we have technically for the biopsy. The instruments that we use are very, very small. The biopsies are 3 French or even smaller, and the specimen is very, very limited. So many times this correlation is poor, but at least we have capability of getting cytology and getting some biopsies, or in some situations you can get like a bigger instrument, a bigger biopsy, get more tissue, but this is not so common. Cytology, just a quick word about that, is very important when we're talking about high-grade disease, ruling out high-grade and CIS. We accept the poor specificity and sensitivity for low-grade tumors, but this is one limitation when we use cytology. Washings typically work better than just voided cytology because then you don't have the contamination from the bladder urine and the bladder urothelium, and also the technique when the sample is obtained is very important, because if you use contrast or if you use any other products inside of the urinary tract, you can alter your cytology results. You're very familiar with the Tnm staging. This is the 2017 version. The difference from the previous 2010 version lies actually on the end stage. So the cutoff size for the lymph nodes is not 2 and 5 centimeters anymore, and there's no N3 categories, just N2. So it's based on one lymph node or less than 2 centimeters versus greater than 2 or multiple nodes, and laterality doesn't matter. Talking about management principles, the radical nephrohysterectomy with bladder cuff excision is the mainstay surgical treatment for all this disease, and generates a lot of concerns and problems because of the very important impact in renal function, decreasing on the patient's global global functional renal parenchyma, and there's always a dilemma: how radical do you need to be to control disease versus how conservative can we be to spare morbidity and mortality in this patient. So some limitations that are inherent to this disease, for example, low-grade tumors, they can be managed by minimally invasive methods, but again, due to the technique and the limitations of instruments, we can only manage some volume of disease, not very large tumors. The thin wall and upper tract favors early invasion, so very often these tumors present already in advanced stage, metastatic stages, so they don't offer the opportunity for us to catch in an early stage. Axial imaging, CT scans, MRIs, PET scans are not very accurate in terms of predicting T stage. So that's a very, very important limitation that we have. And the role of lymph nodes, we're going to see in a little bit, it's also very important. It's a very strong predictor factor. And putting all this in consideration, we also need to weigh very carefully what's the role of chemotherapy in this disease. So just trying to do some risk-adapted management, starting with the non-invasive low-grade tumors. Endoscopic ablation tend to be our favorable initial approach. As long as we can get some reliable staging, we're confident about ruling out CIS or any high-grade disease, meaning our cytology is negative, we don't have any other suspicions elsewhere. And also, it depends on our endoscopic ability to reach the tumor and manage those tumors. So that can be done by ureteroscopy, can be done by percutaneous approach. We can resect, colorize, laser abrade. We can do that multiple times, and they're all safe and effective. But as long as we can keep surveillance, and also this is technically feasible. In terms of high volume, again, that's a limitation. Many times patients lose their kidneys just because we cannot handle our large volume of low-grade disease, and also. If these tumors are more on the mid or distal thirds of the ureter, then we can benefit and do segmental or distal resections and then preserve renal function in those cases. On the other hand, the high-grade non-invasive disease also allows some conservative options, but they're not favorable because there's a high rate of upstaging in this disease. They're often multifocal, and ipsilateral recurrences are very common as well. So in very specific situations, for example, patients with solitary kidneys, bilateral tumors, already impaired renal function, patients that are unfit for surgery, those are the ones that we tend to be a little more conservative and try to be try to spare some nephrons, but this is an important consideration so we don't compromise oncological control. Topical Bcg is something that we use intracavitary BCG especially for carcinoma in situ. This is another tentative of being conservative and preserve the kidney, preserve the nephron units. And again, we can use segmental resection in comparison to the whole nephro-U, but both with bladder cuff excision and also lymph node dissection. For more advanced disease, the conservative options are very, very limited, and we're basically just resorting to the resections and associated or not with a perioperative chemotherapy. Until very recently, there was no level 1 evidence in the upper tract, and everything that was doing was based on extrapolations from the bladder. And many of us was actually offering neoadjuvant chemotherapy for tumors that were high grade, not necessarily invasive or not, because we cannot ascertain that ahead of time, but just having a high-grade tumor would be enough for us to offer neoadjuvant chemotherapy, because many of these patients don't have enough renal function to receive cisplatin-based chemotherapy after the kidneys being removed. Now we have new clinical trials, new emerging evidence that I'm going to show it to you. Just a quick more words about the surgical principles. In the past, and we learned this a long time ago, nephrectomies were not a good approach in these patients. We have to resect the whole ureter with the bladder cuff. The recurrence rates, and though at that age used to be very high, 20 to 84%. The discussion of a laparoscopic approach, pure or hand assist or robot assisted versus open is not a discussion anymore. It's being shown over and over that's been very, very efficient and comparable and safe. And again, The management of distal ureter and bladder cuff excision can be done different ways. You can do intravasically, extravasically. You can do a transureteral resection of the UO. That's the pluck technique to remove the cuff. But one technique that you should avoid is just stapling across. If you dissect through the intramural portion, pull the ureter and staple across that, and some laparoscopic surgeons were doing that some time ago, has been shown to increase margins and affect survival. I'm going to show the data as well. So quickly, this is Seer Data. You can see thousands of patients comparing FRU with the cuff excision versus no cuff excision. You can see the Kaplan-Meier, the survival curves showing the cancer-specific mortality being worse for patients without the cuff. Multiple laparoscopic robotic data. This is being already shown. This is just one of the Japanese multi-center trials, more than 1,000 patients, and you see the overall and the recurrence-free survival rates comparable to the rest of the literature. And this is the data showing why stapling is not the best of the techniques to handle the cuff, increases the positive margins, and that was statistically significant. This was performed by Dr. Serena Martin and Inderberg Gill. The recurrence-free survival, as you can see in this curve, was statistically significant, depending on the cuff method. If you look at cancer-specific survival, that was also affected based on the margins, and also overall survival was affected. So not a good idea. In terms of lymph node dissection, Dr. Kondo from Japan was the first investigator who mapped the lymph nodes from the upper tract. So was suggesting templates where this lymph node dissection should be done based on location of the tumor. The only thing that's being added by recent investigators was the common iliac lymph nodes and tumors that are in the mid-third. But otherwise, the lymph node dissection should follow the location. Again, lymph node, we know this affects survival. Even patients with a negative nodes, the number of nodes and extent of node dissection also affects cancer-specific mortality. So there's a signal there. I'll go to the final part. So let's skip this, and then in terms of new technologies, we mentioned about narrowband imaging. So that's armed endoscopic visualization to aid in the identification of these tumors. So you can see how it enhances our visualization. And this is a technology that's just a flip of a button, and it changes the light and then enhances mucosa in the vessels. This is a proprietary technology from Olympus. Storrs has a similar technology. It's called Chroma. It's also a flip of a button on the scope. So multiple different equipments can provide this type of technology. Endoluminal ultrasound, I'm going to skip that, but also can show details on the wall, tumors growing outside of the ureter. And then just quickly, let me talk about the trials, so don't go over the time so much. This is just to show that over the past 3 decades, up to 2010, survival hasn't changed, and although laparoscopic surgery improved a little bit, the rate of endoscopic approach improved a little bit, chemotherapy was marginally improved over time, survival remained the same without any changes. So now we have 3 studies. I'm going to go quickly that may provide some changes. First of all, mitoGel. mitoGel is a very cool technology. This is a thermoactivated gel that is liquid and fluidic on the cold temperature. So that's how the gel is provided. We inject in the patient, and then when the temperature goes up and it reaches the body temperature, it solidifies and becomes a gel. So this is a formulation that carries mitomycin. So when injected in the upper tract, it holds mitomycin longer in contact with the mucosa. So just to show that on the feasibility studies, we have an encouraging number of complete responses. This generated the Olympus study, so we're doing that study. This is the schema. We're offering a maintenance and induction and maintenance. And let me go quickly to this plot showing complete response and partial response at these rates at the first evaluation 6 weeks after the induction. Very encouraging. This trial is ongoing. We're gonna look at the final results. In terms of the next couple trials in terms of chemo, POUT. I cannot leave this talk about talking about POUT. POUT study is a phase 3 randomized trial made in UK where they look at adjuvant chemotherapy on patients after nephroureterectomy and lymph node dissection. So this is the study schema. These patients were randomized to surveillance versus a platinum-based chemo. So it was gemcitabine versus either cisplatin if they have good renal function or carbo if they have poor renal function. And then they compared the outcomes. They included only the patients with T2 and higher or positive nodes that were completely removed. Going straight to the results, toxicity was expected. You can see the disease-free survival was significant, and the Kaplan-Meier, this force plot favoring chemotherapy versus surveillance. Metastasis-free survival also significant. Overall survival not quite, but probably the follow-up was too short. The investigators were proposing this as the new standard of care, giving chemotherapy in the adjuvant setting. Final one is the study from MECOG and ACRIN. It's a EA8141. We did that through the SWOG as well. So this was a neoadjuvant chemotherapy in patients who were candidates for a nephroureterectomy. This was not a randomized trial. The patients were registered and select to each arm pending their renal function. So good renal function would go into accelerated MEVAC chemotherapy arm, and patients with a poor renal function with a creatinine between 30 and 50 will go to the gem carbo arm. So here, as you can see, complete response, meaning T0 disease, was 14%. If you look into less than T1 or less, meaning down staging, that added to 62% response. So very encouraging results. The arm, you can see toxicity very, very tolerable. The gem carbo did not accrue, have only 6 patients, and probably because the criteria was too strict. But again, very encouraging. We have new trials coming up. This is just a quick list, it's not all inclusive, showing combination of chemo, target therapy, immunotherapy, a lot coming up, and hopefully using genomic as markers for the disease as well. So I'll skip this. But this algorithm is just to summarize everything, including clinical trials, possibly adjuvant for patients with advanced disease. I'll be happy to take any questions.